Welcome to the deep dive. Today, we're really getting fundamental. We're exploring the systems that literally shape how you experience reality.
That's right. We're tackling somatosensory function, pain, headache, and temperature regulation. Think of it as the body's interface with the world and its internal thermostat.
These are the constant background processes, the workhorses, and understanding them is, well, absolutely crucial for pathophysiology.
Definitely. Our mission today is to break down Chapter 14 for you, focusing on the core ideas. We'll look at three main things.
Okay.
First, how we sense things touch, where our body is, temperature, all that neural wiring. Second, we'll really dig into pain, from the initial signal to how our brain processes it.
And third,
And third, how the body keeps its temperature stable. That whole thermoregulation piece.
right, that somatosensory system. It's just incredible when you think about it, feeling a tiny breeze or knowing where your feet are without looking.
Exactly. It's this massive stream of information coming in constantly from millions of sensory neurons.
So let's start with the wiring. How does that information actually travel?
Okay, so the basic framework is what we call the three-neuron system. It's a chain, like a relay race.
3 steps. Why not just one direct connection? Why the need for 3 neurons?
Good question. It's about processing and control. That serial structure allows for things like reflexes and filtering before the signal even hits your conscious awareness.
Okay, makes sense. So the first neuron.
The first-order neuron, think of it as the scout. It picks up the raw data from a receptor out in your skin or muscle and carries it right into the central nervous system, the spinal cord or brainstem.
Got it. Then the second neuron takes over.
Precisely. The second-order neuron does two key things. It connects immediately with local reflex circuits in the spinal cord. That's why you pull your hand back from something hot before you even feel the pain properly.
With a quick reaction.
Right. And then its main job is to send that signal up the spinal cord, usually heading towards the thalamus in the brain.
The thalamus, the big relay center we mentioned.
Exactly. Which brings us to the third-order neuron. This one picks up the signal from the thalamus and delivers it to the finish line, the cerebral cortex.
And that's where we actually perceive the sensation. Like, that's soft or that's sharp.
That's where the full interpretation happens. Location, intensity, what it actually means. So you see, that three-step process allows for reflexes, relaying, and then final detailed perception.
Okay, that structure makes sense. Now, within that, you mentioned speed. Not all signals travel at the same pace, right? That's where fiber types come.
Correct. We mainly talk about two types here relevant to speed, type A and type C.
And the difference is?
Type A fibers are the Ferraris. They're large, covered in myelin, that fatty insulation which lets them conduct signals super fast.
So what kind of information uses the Ferrari?
High priority stuff, precise touch like feeling texture, pressure, vibration, and also that fast, sharp initial pain, the kind that makes you say, ouch, immediately.
Okay, and type C,
Right.
the slower lane.
Yeah, you could say that. Type C fibers are the opposite. Small, unmyelinated, so they conduct signals much more slowly.
And they carry.
Things that don't need that instant reaction or pinpoint location, like warmth or hot sensations, itching, and that slow, dull, aching kind of pain. Also, crude touch, the kind where you know something's touching you, but not exactly what or where.
Got it. Fast A, slow C. Now, before we follow those signals up the pathways, we need to talk about the map, right? Dermatomes. These are super important clinically.
Absolutely essential. A
Yeah.
dermatome is simply the area of skin that's supplied by sensory nerves from a single spinal cord segment, specifically a single pair of dorsal root ganglia.
And why is that map so useful for doctors?
Because if a patient has numbness or tingling in a specific pattern on their body, you can often use a dermatome chart to figure out exactly which spinal nerve root or which level of the spinal cord might be damaged or compressed. It helps localize the lesion.
But it's not always perfectly clear-cut, is it? There's some overlap.
Yes, and that's a really important feature. Neighboring dermatomes overlap quite a bit.
Which is good, presumably.
It's very good. It means if you damage just one single spinal nerve root, you usually don't get a complete loss of sensation in that area. You might get reduced sensation, like hypoesthesia, but the adjacent nerves kind of cover for the damaged one. It provides a safety margin.
Okay, so we have the fibers, the dermatome map. Now, how does this information actually get up to the brain? You mentioned pathways.
Right. There are two main ascending pathways running in parallel up the spinal cord. They carry different types of information, and crucially, they take different routes, especially in terms of where they cross over to the other side of the body.
Okay, let's take the first one, the high-fidelity pathway.
That's the discriminative pathway, also called the dorsal column medial lemniscal pathway. Think of it as the high-definition channel. It carries signals very rapidly.
And it handles the precise stuff.
Exactly. Fine touch, vibration, knowing the position of your limbs without looking, that's called proprioception. It's what allows you to, say, touch your nose with your eyes closed.
And this is related to stereognosis, right? Recognizing objects by touch.
Yes. That ability to identify an object like a key just by feeling it in your pocket relies heavily on this pathway sending detailed information to the parietal lobe of your cortex. And if you can't do that, if that pathway or the cortex is damaged, the condition is called stereognosis.
Okay, so that's the fast, detailed pathway. What's the other one?
The other is the anterolateral pathway, sometimes called the spinothalamic pathway. This one is slower, involves more synapses, more connections.
And it carries the less precise sensations.
Correct. Pain, temperature sensations, both hot and cold, crude touch, firm pressure sensations where the exact location isn't as critical as just knowing that it's happening.
Now, you said they cross over differently. This sounds clinically important.
Hugely important. The discriminative pathway, fine touch, proprioception, travels up the same side of the spinal cord it entered on and only crosses over way up at the base of the brain, in the medulla.
Okay, and the anterolateral.
The anterolateral pathway, pain, temperature, crosses over almost immediately within a few segments of where the first-order neuron entered the spinal cord.
Whoa. So what does that mean if someone has, say, an injury to one side of their spinal cord?
It means you get a very specific pattern of sensory loss below the level of the injury. On the same side as the injury, they'll lose fine touch and proprioception because that pathway hadn't crossed yet. But on the opposite side of the body, they'll lose pain and temperature sensation because that pathway had already crossed over lower down.
That dissociation is a classic sign. That's really key for diagnosis.
Absolutely diagnostic gold, like
Yeah.
you said. And one more thing about the anterolateral pathway. It actually has two parts.
Oh.
There's the neospinothalamic tract, which is a bit faster and carries sharper, more localized pain. Think A delta fibers directly up towards the thalamus and cortex.
Yeah.
And then there's the paleospinothalamic tract. This one is slower, uses those C fibers, and it sends signals not just upwards, but also widely connects with parts of the brainstem and, importantly, the limbic system.
The limbic system.
Yeah.
The emotional brain.
Exactly. This connection is why that slow C fiber pain often has such a strong emotional component, why it feels unpleasant, draining, suffering-like, beyond just the raw sensation. It's wired into our emotions and motivation.
That makes so much sense. It explains why chronic pain can be so devastating emotionally.
Yeah.
Which brings us neatly to pain itself. How do we even define it?
The standard definition from the IASP is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Notice the emotional part is right there in the definition.
And we can broadly categorize pain based on where it starts.
Right. You have nociceptive pain, which is the normal response to injury. Free nerve endings, called nociceptors, get activated by tissue damage like a cut or a burn. That's the signal saying, hey, something's wrong here.
Okay, the expected pain.
Then you have neuropathic pain. This is different. It's caused by damage or dysfunction within the nervous system itself. The nerves are sending pain signals inappropriately, even without ongoing tissue damage. Things like diabetic neuropathy or postherpetic neuralgia fall into this category.
It's the wiring itself that's faulty.
Precisely. Now, how do we understand the processing of these signals? There have been a few theories.
Like the gate control theory. That one seems pretty famous.
Yes, Melzack and Wall's gate control theory was groundbreaking. It suggested there's a sort of gate mechanism in the spinal cord, specifically in the dorsal horn.
A gate.
Yeah, the idea is that input from large, fast-touch fibers, those type A fibers, can essentially close the gate to signals coming in from the small, slow pain fibers, type C and A delta.
So rubbing your stub toe actually helps because the touch signals block some of the pain signals at the spinal cord level.
That's the classic example, yes. It explains why stimulating large fibers can inhibit pain transmission, at least temporarily. It was a huge step forward.
But it doesn't explain everything, does it? Like chronic pain or phantom limb pain.
No, it doesn't fully capture the complexity, especially the brain's role. That's where the Neuromatrix theory comes in.
Okay, how does that build on gate control?
It emphasizes that pain isn't just a simple signal going up. The brain actively constructs the experience of pain. It proposes a widely distributed neural network, the Neuromatrix, that integrates sensory input with cognitive factors like attention, memory, expectation, and emotional input from the limbic system.
So the brain generates a unique, pain signature.
Exactly, a neurosignature. This helps explain why psychological state, past experiences, and even genetics can influence pain, and why pain can persist even without ongoing input from the periphery, like in phantom limb pain. Treatment needs to consider this whole brain-body network.
Okay, let's quickly revisit the speed difference specifically for pain. You mentioned A delta and C fibers.
Right. Fast pain, that sharp, pricking, well-localized initial sensation, is carried by the faster, myelinated A delta fibers. It travels up that neospinothalamic tract. First pain.
And the follow-up pain.
That's the slow pain, the dull, aching, burning, diffuse sensation that often comes a bit later and lasts longer. That's carried by the slower, unmyelinated C fibers, mainly via the paleospinothalamic tract connecting to those emotional centers. Second pain.
But our bodies aren't just passive receivers of pain, are they? We have ways to fight back.
Absolutely. We have a built-in pain modulation system, an endogenous analgesia system. It involves pathways descending from the brain down to the spinal cord to block incoming pain signals.
Where do these pathways start?
A key area is the periaqueductal gray, PAG, in the midbrain. Neurons there project down to the nucleus raphe magnus, NRM, in the medulla, and from there signals travel down the spinal cord, often using neurotransmitters like serotonin and norepinephrine to inhibit pain transmission at the dorsal horn, essentially closing that gate we talked about.
And this involves our natural opioids.
Yes. Critically, this system releases endogenous opioid peptides, things like enkephalins, endorphins, and dynorphins. These bind to opioid receptors, mu, delta, kappa types, in the brain and spinal cord, mimicking the effect of drugs like morphine to reduce pain perception.
Amazing. Now, a really crucial distinction in the clinic is acute versus chronic pain. They seem fundamentally different.
They are profoundly different and need different management. Acute pain is typically short-term, usually less than 6 months. It has an identifiable cause, like an injury or surgery.
And it serves a purpose, right? A warning signal.
Exactly, it's protective. And it usually comes with obvious signs of sympathetic nervous system activation, increased heart rate, higher blood pressure, maybe dilated pupils, sweating. It generally resolves as the underlying injury heals.
Okay. And chronic pain.
Chronic pain persists longer than 6 months, often long after the initial injury should have healed, or sometimes without any clear initial injury. It serves no useful biological function.
And those acute signs are gone.
Usually, yes. The body adapts, so you don't see that constant sympathetic overdrive. Instead, chronic pain is often associated with significant psychological and functional changes. Depression, anxiety, poor sleep, withdrawal from activities, preoccupation with the pain itself.
So treating chronic pain isn't just about blocking a signal.
Not at all. It requires a multidisciplinary approach, maybe physical therapy, psychological support like CBT or biofeedback, alongside medications. And the medications might not just be standard painkillers. They often include things like antidepressants or anticonvulsants that modulate nerve function, especially for neuropathic chronic pain.
Okay. One more pain phenomenon. Referred pain, when the pain shows up somewhere else entirely.
Right. Referred pain is when you feel pain in a part of the body that's quite distant from the actual source of the problem.
Why does that happen?
It happens because sensory nerves from different areas off in an internal organ, visceral, and a patch of skin, somatic, converge on the same second-order neurons in the spinal cord.
So the brain gets confused.
Kind of. The brain is much more used to getting signals from the skin, so when that shared pathway lights up due to a problem in the organ, the brain interprets the signal as coming from the corresponding skin area, the dermatome.
The classic example is heart attack pain felt in the left arm or jaw.
Right, exactly. Or the book mentions appendicitis. The pain often starts vaguely around the belly button, umbilicus, because that's the spinal segment the appendix initially signals to, before it localizes to the lower right abdomen as inflammation progresses.
Okay, just a few quick definitions before we move on. Allodynia.
Allodynia is pain caused by a stimulus that normally wouldn't cause pain, like lightly brushing the skin feels painful, often seen in neuropathic pain states.
Hyperalgesia.
Hyperalgesia is an exaggerated response to a stimulus that is normally painful, so a small pinprick feels like agony. Increased sensitivity.
And neuralgia.
Neuralgia describes severe, brief, stabbing, or lightning-like attacks of pain that shoot along the path of a specific nerve. Trigeminal neuralgia, affecting the face, is a prime example, very debilitating.
Okay, got those. Let's shift gears to headache, a very common type of pain. The source material highlights 3 main primary types.
Right. Primary headaches, meaning they aren't caused by some other underlying disease. The big 3 are migraine, cluster, and tension type.
Let's start with migraine. What are the hallmarks?
Migraines are typically, though not always, one-sided, unilateral. The pain is often described as throbbing or pulsatile. They can last anywhere from hours to typically 1 to 2 days.
And they often come with other symptoms.
Yes, very commonly. Nausea and vomiting are frequent, as is sensitivity to light, photophobia, and sound, phonophobia. The underlying cause seems to involve activation of the trigeminal nerve system and inflammation around blood vessels in the brain coverings.
And some people get an aura.
Right. About 20% or so experience an aura, which is a set of temporary, reversible neurological symptoms, usually visual disturbances like flashing lights or blind spots, but sometimes sensory like tingling that occurs shortly before the headache pain starts.
Okay, distinct from that is the cluster headache. Sounds intense.
Extremely intense. They are less common than migraines, but are considered one of the most severe types of pain humans experience. They occur in cyclical patterns or clusters.
What's the pain like?
It's severe, unrelenting, almost always strictly unilateral, and typically centered in or around one eye or temple.
And they have unique accompanying signs.
Yes, a defining feature is the prominent autonomic symptoms on the same side as the pain. Things like eye tearing, lacrimation, redness of the eye, runny or stuffy nose, forehead sweating, eyelid drooping or swelling. Very characteristic.
Wow. And the third type, the most common one.
That's the tension type headache. This is the one most people experience occasionally. It's generally milder than migraine or cluster.
How is it described?
Usually as a dull, aching, non-pulsating pain. It's often bilateral, meaning on both sides, and felt diffusely, sometimes described like a tight band around the head, the classic hat band distribution. It's usually not disabling, though it can be persistent and annoying.
Okay, that covers the main headache types. Now let's move to our final topic. Temperature regulation. Keeping the body's core temp stable.
Right, thermoregulation. Our core body temperature is normally kept in a very narrow range, around 36.0 to 37.5 degrees Celsius, or about 97 to 99.5 Fahrenheit.
And the control center for this is?
The hypothalamus, deep in the brain. It acts like the body's thermostat, constantly monitoring blood temperature and receiving input from temperature receptors in the skin and core.
So when we get too hot, how does the body cool down? There are four main ways, right?
Yes, 4 mechanisms of heat loss. First is radiation. This is just the transfer of heat through electromagnetic waves, like heat radiating off your skin into cooler surrounding air. It accounts for a lot of heat loss, maybe 60% when you're just sitting in a room.
Okay. Second.
Conduction. This is direct heat transfer from your body to a cooler surface you're touching. Like sitting on a cold metal bench or using a cooling blanket in a hospital, heat conducts directly away. Convection. This involves heat transfer through the movement of air or water currents across the skin. A breeze blowing past you carries heat away via convection. That's the principle behind wind chill making you feel colder.
And the last one. Crucial when it's really hot out.
Evaporation. This is the conversion of liquid water sweat on your skin into water vapor. This process requires energy, and it pulls that energy, as heat, away from your body. Critically, it's the only way the body can lose heat when the surrounding air temperature is actually higher than your skin temperature.
Makes sense. Now, the really critical clinical point here, the difference between fever and hyperthermia. People mix these up all the time.
They do, and it's vital to distinguish them because the cause and treatment are different. Fever, also called pyrexia, is a regulated increase in body temperature.
Regulated, meaning the thermostat setting changes.
Exactly. The hypothalamic set point is actively raised. This usually happens in response to infection or inflammation. Substances called pyrogens, either from bacteria, exogenous, or released by our own immune cells, endogenous, trigger the release of chemicals like prostaglandin E2, PGE2, in the hypothalamus.
And PGE2 tells the hypothalamus, okay, 39 degrees is the new normal.
Precisely. The body then thinks it's too cold relative to this new, higher set point, and it activates heat-generating mechanisms, shivering, vasoconstriction, to reach that target temperature.
And we see stages with fever, right?
Yes, typically 4 stages described. The prodrome, feeling unwell, then the chill stage, shivering, feeling cold while temperature rises, followed by the phlegm stage, feeling warm, vasodilation once the set point is reached, and finally defervescence, sweating, cooling down as the set point returns to normal, maybe after antibiotics kick in.
Okay, so that's fever, a change in the set point. How is hyperthermia different?
In hyperthermia, the hypothalamic set point remains normal. The problem is that the body's heat dissipating mechanisms are simply overwhelmed. Either the body is producing too much heat, like during extreme exertion or due to certain drugs, or it can't lose heat effectively to a very hot environment.
So the thermostat is set correctly, but the air conditioning is broken or the furnace is stuck on full blast.
That's a great analogy. Think of heat exhaustion or, more severely, heat stroke. The body temperature rises uncontrollably because heat production or gain outstrips heat loss.
And clinically, very high temperatures suggest hyperthermia.
Generally, yes. Core temperature is above, say, 41 degrees Celsius or about 105.8 Fahrenheit are usually not due to a regulated fever. That level points towards hyperthermia, where the regulatory system itself is failing or overwhelmed or maybe direct damage to the hypothalamus. It's a medical emergency.
Okay, crucial distinction. Lastly, what about low body temperature? Hypothermia.
Hypothermia is defined as a core body temperature below 35 degrees Celsius or 95 Fahrenheit. It happens when heat loss exceeds heat production.
And certain groups are more vulnerable.
Yes, infants are particularly susceptible. They have a larger surface area relative to their weight, meaning they lose heat faster, and they have less insulating subcutaneous fat.
They can't shiver effectively either, right?
Right. Instead, infants rely heavily on non-shivering thermogenesis. They metabolize a special type of fat called brown fat, which generates heat directly without muscle contraction.
Interesting. And we also see hypothermia in surgery.
Yes, perioperative hypothermia is quite common. General anesthesia tends to inhibit the body's normal thermoregulatory responses like vasoconstriction and shivering, making patients prone to cooling down in the OR environment. Hospitals take steps to prevent this.
Okay, we've covered a lot of ground: sensation, pain, temperature.
We have. So maybe to wrap up the key takeaways. First, remember that 3-neuron relay system for sensations, it's essential for processing. And know those 2 main ascending pathways. Discriminative for fine touch crossing high up, anterolateral for pain temp crossing low down.
Second, the pain distinctions. Fast A delta versus slow C fiber pain, and how the latter links strongly to emotion via the paleo-spinothalamic tract, plus the body's own opioid system for modulation.
And third, that vital difference between fever, where the hypothalamus deliberately raises the set point, and hyperthermia, where the set point is normal, but the cooling systems are overwhelmed. Recognizing that difference is key.
Understanding these foundations really helps make sense of clinical science, doesn't it? From mapping germatomes to pinpoint nerve damage to managing chronic pain effectively, or knowing when a high temperature signals dangerous heat stroke versus a controlled fever.
Absolutely. These aren't just abstract concepts. They explain what you actually see in patients.
Now, for that final thought for you, our listener, to consider. We talked about hypothermia being dangerous, especially uncontrolled drops in temperature.
Right. Metabolism slows, organ function can fail.
But think about this. Doctors sometimes intentionally induce therapeutic hypothermia. They deliberately cool a patient's body down, often to around 32 to 34 degrees Celsius, after events like cardiac arrest or certain brain injuries.
It seems paradoxical, doesn't it?
It really does. So reflect on why lowering the body's temperature in a controlled way, temporarily suppressing that normal set point, is actually used as a protective strategy in critical care. How can slowing things down sometimes prevent further damage, even though uncontrolled cold is so harmful?
A fascinating point about control versus pathology, something to mull over. Thank you for joining us for this deep dive.
We really hope this breakdown of sensory function, pain, and temperature regulation was helpful for you. We'll catch you next time.